And let me go ahead and introduce you, Kathleen. So to everyone out there, Dr. Kathleen Barnes has been very kind this morning to give us an update on the personalized medicine program, especially what's going on at CU Anschutz. And I think, as everyone knows, this is really not only an exploding field, but a critical field to help guide us what we do in the clinics, wards, and operating rooms. She's a professor of medicine. She's the director of the Colorado Center for Personalized Medicine. And just to give you an idea of how important this program is on campus, the funding for this is basically in the 9 digits, and it's accruing funds from all kinds of sources, philanthropy, all the different schools, and really is one of the largest programs now on campus. Dr. Barnes received her bachelor's in nursing from the Medical College of Virginia, and then went on to do a PhD in anthropology at the University of Florida. She did her postdoctoral fellowship at Johns Hopkins in the clinical immunology division, and she quickly went on faculty and rose through the ranks, and became actually the director of the genomics core at Johns Hopkins, and also ran the Bayview Genetics Research Facility. We were very lucky to be able to recruit her to our campus, and really over the past several years, Dr. Barnes has really accomplished a lot, and we're going to hear more about it this morning. So Kathleen, please go ahead.
No, such a kind introduction. Thanks, Rich. So I really appreciate the opportunity to meet with all of you all this morning, on the snowy morning. I'm looking out the window, and to share with you what we've built over the last 5 years. So I'll jump right in. How we define personalized or precision medicine. There's lots of different definitions we think of. It can be in the context of risk assessment, how we use genetic testing to make determinations about an individual's predisposition for disease. A lot of attention these days on prevention, so integrating things like wearable devices and integrating behavioral data to make predictions and ultimately prevent disease. Early detection of disease at the molecular level. So again, we think of genetic testing to say, well, you're at risk for developing disease X. What could we do in the interim to mitigate that? Using personalized medicine for better diagnosis and improved treatment to prescribe the right drug to the right patient at the right time. And ultimately management. And we focus a lot on disease, but really I would turn it on its head and say what personalized medicine really has the power to do is to help us stay healthy. So in the next 20 to 25 minutes, I'm going to really focus on these 3 areas, that is risk assessment, early detection, and particularly treatment. And I think that's where the Department of Surgery has been most engaged with our program, and I want to touch on that just a little bit. So when we think about how personalized medicine can impact lives, and really focusing on genetics, and most of my presentation is going to focus on when we think of omics, genetics. In particular, up to 80% of the population can benefit from knowledge around pharmacogenetics. Around 91% of the population can benefit from carrier status. And about 20% of the population could benefit from knowing if they do or do not have risk variants associated with traditional Mendelian disease. So in thinking about how to build a personalized medicine program, when I moved out here 5 years ago, really the only piece in place was this, the health data warehouse, what we call Compass, on campus. That had been formed the year before I got here in 2015. And really we needed to build everything else. And this isn't a novel concept. Personalized medicine programs already existed across the United States and had been really entrenched in programs. You think of, for example, partners at Harvard, Vanderbilt, Mount Sinai. They had already been in place for about a decade. And the formula for doing so is really something like this. So you start with the patient population, We have until now really focused on the UC Health adult population in building our program. And we know there's just under 2 million active patients in the UC Health system across the state and region. We leverage the rich electronic health record data from that patient population. And again, this all feeds into our health data warehouse Compass, which actually includes data from both UC Health and Children's, as you most likely know, over 8.7 million patient records to date in Compass. And then we needed to think about, well, what else do we collect from the patient population to be able to move forward with personalized medicine? So we needed to build a biobank. We spent a lot of time thinking about what we wanted that biobank to look like, and I'll tell you more about that. To date, we have over 135,000 participants in the biobank. And then we needed to make a decision about what we were going to do with those specimens once we collected them. And I'll share with you what our program is really focused on around large-scale genotyping of the population. And we have a little over 30,000 of those pieces of data to date. And then it was critical to build the computing infrastructure to bring all of these data together for the computing, networking, and storage needs of really big data. So I'm going to start with the Health Data Warehouse, or Compass, and really what CCPM has done to bring all of these pieces together. So many of you are probably already familiar with Health Data Compass. This is our enterprise research data warehouse. Just as I just mentioned, just under 7 million patient records to date. About 2.5 million of those have extensive clinical data. If we put all the data together, we have around 1 billion facts. That's a lot to get your head around. And they're both internal sources of the data, that is, for example, the EPIC data that comes from the different healthcare systems, as well as multiple external data sources, which most people don't think about and aren't as aware of. This number has actually changed since COVID because Compass has been quite busy with COVID, but these statistics at the beginning of March were something like this. We have a little over 900 unique investigators who have leveraged Compass over the last 6 years. More than 750 data sets have been delivered to date, and more than 700 self-serve queries. These are the different types of analytic platforms that we offer up in Compass. And really a major goal in Compass is to create an environment that's very much self-service. So you, the investigator, can go directly to Compass yourself, query Compass for what you want to know about Compass. If you need a more sophisticated data set from Compass, we offer Eureka. And also through the high performance computing system we call Roslyn, much of these activities can take place in that computing environment. All of Compass is on the cloud. We're actually the first health data warehouse to move wholly to the cloud. How do we piece all of this together? We have a long-standing partnership with a company called BC Platforms, and this is really a leader in the space of genomic data management solutions. And so BC Platforms intersects in different spaces within the CCPM in linking data coming from the biobank with the electronic health record data, for example, as we return results, and also over in the analytical space. So when I first got here, again, lots of reflection on what was already out there and what did we want our personalized medicine program to look like, and what could be the differentiators. And so we hired a marketing firm and did a landscape overview. So this is back in 2015, and some of these figures have changed. But we really focused on to what extent programs out there were very, very focused on research versus those very focused on clinical applications. And what we wanted to create in the Colorado Center for Personalized Medicine was a highly integrated program, which really allowed us to do both. So we started with the biobank. We made a very important decision early on, and we're glad we did it. We created a biobank that's actually a CLIA certified research biobank. And what that means is as data comes into the biobank, it allows us to directly return clinical results to our participants. We're currently in the middle of our CAP accreditation application. We sit over in biosciences too. We're actually going to move into the new Anschutz Health Sciences building in 21 on the top floor with a greatly expanded footprint. We have fully automated DNA extraction platforms. We're able to do clinical validation of the genotyping platform that we use. Our genotyping capacity will expand greatly when we move into the new space at over 125,000 samples per year is what we'll be able to do. And we also have the ability for Sanger sequencing validation, as well as headroom to expand to whole genome sequencing. So what does the program look like? This is really a layout of what happens if you, a UC Health patient, decide you want to participate in the CCPM Biobank and that workflow. So first, and I'll explain how this is happening, all of our consenting is done electronically through the patient portal, My Health Connection. Patient reads the consent in that portal, and that triggers an automatic, a dedicated blood sample. So the next time the patient comes into the UC Health system, has a blood order, a dedicated tube is collected and sent over to the biobank. That is immediately extracted for the DNA, and then the genetic data are generated from that dedicated sample. And then ultimately the goal is to return genetic results back to our participants. So what that looks like on the My Health Connection portal, here's Jane Doe, and she's going into the portal. And she gets a pop-up that says you have 2 consents that need to be reviewed, and one of them is in fact the biobank consent. She can click here to get more information, and specifically down in this corner, there's more information about what is personalized medicine. We've created an educational video that the patient can link to for more information. And once he or she has done that, then there's the opportunity to view the consent, either sign or decline the consent, and we're able to track who declines so that we don't continue to offer that up each time they go into My Health Connection. Some really unique features, and we believe we're the only institution enrolling patients into our biobank this way, and I really have to shout out to Steve Hess and the IT team at UC Health who have made all of this possible. Patients agree to be recontacted, so if they're in our biobank and you, a researcher, have a question or a study that you want to start, you could actually recontact participants in the biobank to participate in those studies. They agree that data can be shared. This is broad sharing, for example, through NIH's dbGaP. It also includes sharing with industry partners. And you agree to receive genetic test results. And I've already mentioned that the consent itself triggers that automated blood order. So where we are to date, as I mentioned, we have over 135,000 participants enrolled since we actually launched the consent in 2016. This does make us one of the largest biobanks in the country, even though we're one of the youngest. A fun fact, since COVID and the need for patients to contact their providers and seek healthcare strictly through telehealth and virtual health, we saw a 40% increase in our consent rate in the month of March without any marketing. So that number, 135, is actually growing quite quickly. We have over almost 60,000 blood samples collected to date. Why that disconnect? Because patients are going to consent, and then there's going to be a delay before there's actually an opportunity to collect a blood sample. You see we have quite a distribution across the state and region, where actually more than half of our participants are coming from outside the Metro Denver area, and we like that because we take pride in having a demographically diverse biobank. Our plans for the next 5 years, which started this past July 1, is considerable expansion and enrollment, and we have a goal to increase our numbers up to 100,000 samples per year starting this year. And this is all going to happen through really an augmented effort between CCPM and the UC Health team and a marketing campaign. If we take a step back and look at CCPM compared to other biobanks out there, there's a really nice review that came out this past year by colleagues of ours at Mount Sinai that did a survey of the different biobanks globally. These are color-coded according to to ethnicity. So red for the Asian biobanks, if you will, blue for predominantly European, and the green represents those biobanks where there's considerable ethnic and racial diversity. And you see the Colorado biobanks, we're one of the newer ones, so we're a smaller circle, but we are one of the more diverse biobanks. And one of the reasons that we think that we have an opportunity for this is because of where we are geographically. We do have the opportunity for an exceptionally diverse patient population compared to some of the other biobanks in the US. And we spent a lot of time thinking about ancestry and the importance of ancestry in both the research space as well as clinical deliverables. So these two individuals, Chris and Jonathan, run a center within the center that focuses wholly on keeping track of ancestry in our biobank and diversity, and are creating what we consider sort of added value to being a participant in the biobank. So for example, to be able to return a sort of Ancestry.com or 23andMe report about each individual participant, we're able to do that because of the information we're collecting on Ancestry. So I mentioned at the outset the importance of choosing the platform that we're going to use. What data are we going to generate from a biobank as we create it? And that forces us to think about these two options around clinical implementation. So a reactive clinical implementation model would be we collect a lot of samples. We might extract the DNA, but then it sits there until we want to ask a question of the data set. This is what we consider sort of just-in-time genotyping, if you will. Where we really want to be is in that preemptive space, where we have the data sitting there so that we can make decisions at the point of care. And truly, when we think about where personalized medicine is heading in the healthcare system, I always say to the team, in 5 years, there shouldn't be a center for personalized medicine. It should simply be the way we implement medicine in our healthcare systems, where every patient coming through the door has a DNA sample collected and the genetic data are there and in the health record for you, the providers, to make decisions about those patients. So how does this actually work in real time? Well, going back to the platform itself, in the ideal world, we'd love to whole genome sequence everybody who walks through the door. Clinical whole genome sequencing is probably still close to $2,000, a little under $1,000 for research purposes. So that certainly isn't scalable when we think about the size of the UC Health patient population. A wonderful alternative to whole genome sequencing is genome-wide association study, or GWAS level genotyping. And from that, we can actually garnered quite a bit of information about the individual. When I was back at Johns Hopkins, we had a large NIH program where we focused on creating a specific SNP chip, if you will, to fill in the gaps in populations of African ancestry. And we then partnered with the NHGRI PAGE Consortium along with Illumina to create this mega chip, if you will. And so this is a chip of just under 2 million SNPs that really captures diversity globally. And we were able to enrich this chip for considerable clinical content as well as exome data. When we just made the decision to leverage this mega chip in the biobank, we sent out an RFI in 2015 to the research community at Anschutz, and we asked everyone, you tell us what's your favorite gene for your favorite disease and what variant should we add to this chip if they're not already there. Excuse me, this shows you enrichment in these different areas for which we were able to add content to the chip and create what we considered a University of Colorado signature SNP chip. In particular, we were able to add considerable pharmacogenetic content to the chip that didn't already exist, making our University of Colorado mega chip the most effective chip that can deliver the most in terms of returning pharmacogenetic data. So as I mentioned, it's right around 2 million variants, this chip. And the clinical content that's on the chip really allows us to go back to those areas I mentioned at the outset of the talk: pharmacogenetics, carrier screening, and clinical findings. When we put our SNP chip head-to-head with whole exome sequencing, we're able to predict about 92% of actionable genetic variation that would be on the exome. And this is all done at less than 10% of the cost of doing a whole exome sequence. So I'm going to focus now on pharmacogenomics. First of all, how do we make decisions and select and develop the drug-gene pairs that we want to focus on first? There are many, many options, obviously, on this chip. It starts with, I really have to shout out to Chris Aquilante and Dave Kao, who run our Pharmacogenomics Implementation Committee of Colorado, or what we fondly call Piccolo, and the very close collaboration we have with the Skaggs School of Pharmacy. We created these 4 steps, if you will, to help us, to guide us in making decisions on which drug gene pair we're going to roll out each time. Much of it is based on evidence, the literature, national guidelines, making smart decisions about what drug gene pairs we should focus on first. Step 2 really involves stakeholder engagement, and that's where folks like Chris, Dave, and other members of the team reach out to clinicians such as yourselves to get your take on what would you like to see in that EHR. What do you want that clinical decision support to look like? Once that stakeholder engagement takes place, then the team moves forward with building and testing a clinical decision support solution. And that build actually is very time consuming, and it's tailored for each drug gene pair. Once that's done, the team has to go back out to both providers and the patients for education and communication. The evidence that we use comes largely from PharmGKB and the Clinical Pharmacogenetics Implementation Consortium. These are national organizations that help us make decisions about which drug gene pairs should be in the, at the point of care. Excuse me. And much of it relies on FDA drug labeling. And this is really a moving space. So very recently, the end of February, actually, the FDA announced new web-based resource, a new organization, if you will, a new process for making decisions around drug gene pairs. Where CCPM is today, just to put it in context of what we've done since we began rolling out pharmacogenetic results into the electronic health record at the University of Colorado. This actually started in July of 2019 with clopidogrel, with CYP2C19. We got a lot of mileage out of CYP2C19. That's the gene. There are variants within CYP2C19 that are relevant to multiple different drugs in these different categories, as you can see. Most recently, Department of Surgery was approached. It's around NSAIDs and their relevance in also primary care and rheumatology. And the newest drug that we're focusing on is the gene itself is DPYD, and this is relevant to oncology. And this will be our first pharmacogenetic drug gene pair, if you will, from CCPM focused on oncology. And we believe that this is highly impactful, potentially very impactful, because knowing this information before one prescribes these particular chemotherapeutics really could save a patient's life. A snapshot of where CCPM is, if you will, in terms of our clinical decision support build out. We first went live with 1 gene and 5 drugs. What we have underway are 12 drugs from just 3 genes. And for this fiscal, the end of this fiscal year, our plan had been to expand that for a total of 4 genes and 17 drugs. I will tell you all, we're a bit stalled at the moment because the build out is very much dependent on the IT team at UC Health, which has been obviously quite busy working on the pandemic. So we're a little bit on hold or delayed in rolling these out, but we hope that in the coming months we'll be able to resume that. What's next for pharmacogenetics at the Colorado Center for Personalized Medicine? Well, I've talked a lot about this mega genotyping chip, and there's actually a new generation of this chip called the Global Diversity Array from Illumina that we are actually piloting a beta tester for this new product of Illumina's at the moment. If we think about the mega chip, there's an additional 6 genes that we can technically and analytically validate in the biobank that will be associated with 6 new drugs. And this would give us, at the end of the day, with the mega chip, about 23 drug gene pairs that would be in the UC Health electronic health record with clinical decision support. If we can move forward with this new chip, the GDA, it only really changes by 3 additional genes, but these genes are so impactful that this would actually give us an additional 47 drugs. Those genes are CYP2D6 and 2 HLA genes, A and B. If we can move to this chip, this will enable us, ideally by the end of the calendar year or certainly by the end of FY21, to expand our program to 70 drug gene pairs within the CCPM. How many patients benefit from having this kind of information? Well, about 99% of the population is going to carry an actionable PGX variant. And at least 1 of 5 of these key PGX genes that are listed here. If we just think about the CYP2C19 example, which we've already rolled out, about 57% of our biobank participants are not CYP2C19 normal metabolizers, so they benefit from that information. About 15% of the UC Health patient population is on at least 1 medication that's affected by this particular gene. And about if we had 500,000 biobank participants, you can do the math and estimate that almost 43,000 of those would have CYP2C19 genetic information in their electronic health record that may be useful for their clinical care. When we look at the national landscape now, we know that we are the largest biobank, so greater than 40,000 samples, that's also returning genetic risk variants and including pharmacogenetic results. So we're very proud of this. This makes us stand out, we believe. We recently published this manuscript, which has already received a lot of hits, which really describes the program and how we've built it out and sort of the unique features around that. Our current directions, I'll just round out then, is that we really emphasize research and the opportunity for research, and I hope that you will reach out to us with ideas of your own, how you could leverage the large-scale genomics that we've generated. We're creating off-the-shelf GWASs, the sort of push-button GWAS that you would be able to do yourself. Also PHWASs that would be made available to the research community. There are a number of federally funded initiatives underway in CCPM. One that we're particularly proud of is a focus on polygenic risk scores. That's how we bring all of the GWAS data together. And there's a large initiative underway, multiple biobanks working together with almost 6 million, representing almost 6 million patients globally. We want to greatly expand the clinical implementation and now move into return of other types of genetic results. So results such as the ACMG 59, for example, the cardiomyopathies and cancer risk. We have an innovations task force in place to help us figure out how we're going to do this in a scalable fashion. It will certainly include quite a bit of virtual health, if you will. And so to close, I hope I've been able to convince you that we've undergone a lot of growth in a very short period of time. We're one of the first enterprise health data warehouses, as I mentioned, on a public cloud platform. We're one of the only personalized medicines with a CLIA and hopefully soon CAP certified biobank. That is a research biobank that allows us to return clinical results. We're the first biobank to leverage this research GWAS chip in a clinical fashion. And we're one of the first programs to launch clinical integration of pharmacogenetics via this research biobank. And as I mentioned, we're currently scaling up with a goal of 500,000 participants by 2025. 25. So I'll end there. Lots of folks to thank. This is CCPM at our retreat last fall. We work very closely with investigators at other institutions and other biobanks, and especially closely with our industry partners, BC Platforms, Illumina, and Google Cloud. So thank you.
Dr. Barnes, that was awesome. Because of time, I'm going to have people email you with questions.
That sounds
but let me just summarize my view of what you're doing. So I think since genomic sequencing came online, that's created a huge amount of chaos, not only in the scientific fields, but also in medicine. And what you're doing is really putting order to all that chaos. And these types of activities, I think, are what distinguish academic medical centers and bring them to the top. Of course, clinical care is very important, education, very important, but I think activities like this is what brings an academic institution into the top 10. And thank you so much for taking this lead and giving this talk this morning.